There we go. Good evening, everyone. They used to call us IMG Research Academy, but because people are joining us all over the world, and especially mostly in the US, some US graduates are also joining. We felt there was a need to change our name to Global Research Initiative, and that's we're gradually transitioning. We're in the process of registering it to do business as Global Research Initiative. We usually focus on clinical research, how to talk about everything clinical research. That we've been doing for about 6 years plus now, or 5 years plus. But we noticed that there's also other needs in life, like how do we get better as physicians to to serve our community better. On that phase of getting better as physicians, we decided to organize ourselves into support group and then bring expert opinions speakers to tell us one or two things about how to survive, especially after we march into residency. Today we are having two very well respected physicians who have excelled exceedingly. I use the word exceedingly. I'm not trying to be over generous with words. One of them is Dr. Janet Omole. She's going to give a little bit of her background in her opening speech. Janet Omole is an internal medicine chief resident in a program in Chicago. I'll let her do more of her introduction when we get there. And then Dr. Endurance, his last name is always something I struggle with. So I'll let him say his last name himself. He's also a chief resident also. So when they say you're a chief resident, that means you're leading the rest of the resident. For those who haven't gotten into residencies, actually a very highly esteemed position. Before a program looks at you and say, you're going to be our chief, you're going to mentor other people coming behind you and then show them the way on how to be a model in residency. Today, our topic is excelling in residency. They're going to give us everyday experience, however they want to, talk about it. It's going to be casual conversation. Some few questions I want to ask. They're free to diversify their thought process, move from one area to another. But for the most part, it's going to be like a question and answer interaction, kind of interjection, kind of setting. And everyone is free to send in their question. If you have any question at any point in time, because it's a semi-formal kind of conversation, please raise your hand. We'll identify you at any point during your conversation for clarification. Dr. Janet and Dr. Endurance, welcome to, I'll not use the word our show, our forum, where we kind of want to get better as physicians so we can serve our immediate community and the world. First, Dr. Janet, let's get a little bit of a background, other things you want to say about yourself. I know there's a lot in your resume, but let's see if you can summarize it in 1 minute.
Okay, hi guys, nice to meet you all once again. Like he has rightly said, my name is Janet Omole. I am obviously Nigerian. I met Dr. Eddie through, the research platform, and it's been an absolute blessing. Love what you're doing for the community. I really do appreciate it. I myself, I tapped into that blessing. For me, I'm a third year resident, already transitioning into chief year. So I'm going to be a PGY4 chief. Um, Very passionate about medicine, being a doctor, very passionate about medical education. I am very passionate about advocacy. If you mention my name in my program, that's one thing I always stand for. I advocate for not just my patients. It brings me so much joy to advocate for my colleagues, my junior residents, my med students, teaching, non-teaching staff. And that's the reason why, I thought about it. I was like, what best suits um this futuristic goal, and nothing other than using this chief residency as a platform, as a good template to ultimately become a program director, or at least an associate program director. I enjoy medicine so
I
much
like
that
that because very few people want to go into, very few of us want to go into this. Yeah, sorry for
hold
interrupting you. Go ahead.
on.
Yeah.
That's okay. They used to call me the confused resident, but it was a good confusion in the sense that every rotation I did, I saw myself being that specialist. I wanted to do EMONC, I wanted to do GI. At some point, I chased cardiology. At some point, I chased crit care. Ultimately, I was like, you know what? If I like everything this much, it just means I'm not ready to specialize. I love being an hospitalist, but if push comes to shove, I feel like I don't like being an hospitalist anymore. I would ultimately pursue being an intensivist. So I would do fellowship in critical care. But in the meantime, like Endurance said, impact, purpose, curiosity, that's really, and advocacy is really what I stand for. So help me God. Thank you, guys.
Amazing, amazing. Dr. Endurance, I
Yeah,
know
Janet just
again
gave
that your resume can be like 50 page, but let's keep it down to 1 minute.
Janet just gave us a manifesto. Janet, they are going for president or presidency. Okay, hi everybody. Good evening. My name is Endurance. I'm from Nigeria, Edo State, Benin City. I went to Benin University. I am a third year chief at St. Luke's Hospital in Missouri. I start my fellowship in July. I go to the University of Massachusetts. What am I passionate for? Oh my goodness. I am passionate about information. I think 90% of people do not have the right information. And the thing that keeps us from achieving our goals is just that information. So whenever I'm able to dish out information that I have gotten through my experiences or through the experience of people that I know, I'm very happy to do that. So giving out information will help people achieve what they want to achieve, and being able to get a lot of wealth of knowledge, wealth of experience, and then translate it back to Nigeria and Africa down the road is also something I'm considering. I'm very glad to be here. I am hoping that the information will give you guys today will be helpful sometime in the near future.
Thank you so much. So let's take you back a little bit to 3 years ago when you started this journey, because your our conversation is going to be basically when residents resume in July, and how are they going to adapt and then excel and then go from there. Bearing in mind that we're talking to two different sets of countries, residents in the US and also residents in Canada. Both of us have similar residency training. There's really nothing much difference in our residency training. Dr. Janet, how was it for you 3 years ago? You came into your hospital. Just let's go back to like deja vu, memory lane.
Going back memory lane, I remember being very anxious. I remember during the day of orientation, it was a mixed feeling of being very grateful because I would always see coming to United States to begin with as a privilege. I always treated that as a privilege, and I feel like that's one of the things that has brought me thus far. But also I was very anxious. So for every time, we had faculty come talk to us, I had a lot of questions. Will I be good enough? Do I have enough foundation to be able to? I don't even know if Excel was the first thing that was coming through my mind. Maybe because of the horrible stories I've heard from, friends in other programs, it was more like surviving, right? So I was very anxious to say. Um, and I know one of the boot camp thingy that I'm putting up together for my incoming interns is if you're anxious, if you have palpitations. Dr. Endurance can probably back me up on this. If it's sinus tachycardia you're having, I think that's okay. It just tells you that you know you have something to lose. You care enough. That's what it means. Now, if you're confident that you know what, I'm going into residency, I'm about to kickstart this process. Honestly, it's not bad too. I think where you need to draw the line is if you're overly confident and nothing bothers you. That's the dangerous zone that you don't want to be in. So going back memory lane, yes, I was anxious, as most Nigerians were very self-critical. So there was a lot of self-doubt, that started, that like, initiated or was brought into light very early on. And I'm trying not to be negative. I would try to be as realistic as possible.
Yeah,
The
that's what we
imposter,
need. That's
the imposter syndrome
realism.
will kick in. It will kick in. Trust me. When you're sitting with, the AMGs, the white, they're more outspoken than us. You're already doing one plus one calculation. Hey, how am I supposed to survive in this one like this? So that's in a way kind of comes with the package. But as we delve deeper into this whole storyline, we'll be able to share with you like things we were able to do to maneuver all these things. It's just like when you put detergent in water, and when you do this with the
Yeah.
water, it creates this old bubble, big bubble. But then when you put your finger through it, it's nothing. All those things are just things that I'm very spiritual, so I would say the devil is just trying to play legwork with you. It's all a lie. It's all a lie. So I'm hoping, with this forum, we're able to share with you, how we overcame it. But to be realistic with you, I was very anxious. I was.
And Doris, how was it for you?
Yeah, I mean, I think I will back up Janet's say. There's always a little bit of, that question of, will I be able to adapt? Will I be able to handle what's thrown at me? There's always that slight thought in your head. Now, I am a little bit overconfident of myself. A little bit. Okay, no, that's not true. Very, very overconfident in myself. However, when I was starting residency, I was like, I don't know, see the bill, make I package myself well. And like she said, it's really, really true. You've marched and now you all eyes on you. You are the Nigerian in this program. You're probably not going to be like two Nigerians. You're more likely going to be just a single Nigerian. Because like in my program, I was the only black guy at that time, you know? And so the question is going to be, oh, who this black guy, is he going to do well? All eyes on this guy and that kind of stuff. So you will begin to feel pressure that you didn't know existed. Just you didn't even know that this pressure could exist, and then there's pressure. But after you've gone through the ladder and then you put your hand, you see it's just cloth we're about to wash now, no level. So for the most of you, it's like the first few days, of course, you'll be anxious. Every single person. There is nobody, There's nobody that used to chop bottle. All of us are anxious, man. There's nobody. So feeling anxious is normal. So when you go out and when you like in the next few weeks, when you're about to resume, you feel anxious, which is very normal. It is the butterfly in your belly. It is the Lord's doing, and it's marvelous in our sight. So it's okay to be anxious.
Sounds like this. There's a common theme. Or what other characteristics of an intern would you say? Because you've now led people well over. I know your program is well over 20 residents. You've seen interns come, interns go, 3 year cycle. What other thing have you? Let's pitch this question to Janet. What other thing is common in interns? And then there are so many interns currently listening to you. I could see them all logging in. Let's see if you also have other characteristics that you've seen in other interns. Like for me, I've seen, not just only nervousness, but also fear. Fear, there are two different things. One is nervous, one is fear, one is feeling of incapacitation. The other one is also at the other extreme, like I know but better than the system kind of intent. Jenna, what other things have you also seen?
Oh,
Very common.
that are common. I feel like you have the two forward intern, the one that doesn't feel like needs to ask the seniors about, decision making, and sometimes works for them, sometimes works against them. Um, the very timid ones. Again, it could be as a result of, like Endurance said, just being anxious. For some people, that's just their personality. I think that's one thing I'm beginning to understand about people, like the difference in personality and what it translates into like the clinical world and clinical medicine. Um, the very coachable ones, those are really the ones that people tend to really like. If I'm being honest with you, those are the ones that tend to excel. um you can just tell some interns are just very thirsty for knowledge, and they amplify whatever you've given to them. um I feel like I'm blanking out now, boys. Like
And Gerald, let's see
yeah.
if you also noticed other characteristics in interns.
Yeah.
And we all come as interns, we come in with this naivety,
Mhm.
several traits that probably many of our interns that are going into their first year we also have unknowingly. Some of them are very unknowingly. Um, like I've noticed people loss of ability to use technology, let's say
Mhm.
navigating the EMR, poor communication skill. If you can add more to what Janet has already built on.
Yeah, I think in the first few months, those things are not as important. So like so there's a timeline when people come the first week, the first month, the first 3 months. There's a timeline. In the first week, almost everybody's timid, right? Nobody's talking. Even the Americans don't talk in the first week. But then after the first week, this first month, we're looking at people who are they asking questions? Are they asking correct questions? Are they not asking questions and making mistakes? So as you see people who are at both extremes, the ones that ask, just like she said, the ones that ask little to no questions and the ones that ask too much questions, like extremely extreme questions. You have to find that we're looking for the people that are in the middle that ask very reasonable questions that, of course, we expect them not to know. We're not looking for people who are asking every single thing. Now, we're also not looking for people who don't want to ask questions at all. There are people like that, they don't ask questions, they just try and, dabble their way through whatever they're doing. And that's one kind of person. So just being curious and asking questions. Then we're looking at people that are trying to be familiar with other people very too soon. You don't want to be too forward too soon. It's just a week. We're not buddies. We're colleagues at this time. But there are people that are like completely withdrawn and socially withdrawn. They are not like even talking to anybody. They're just on their own. You want to be that person that is saying hi, but not asking how's your child.
Right.
You know?
Right.
So yeah.
Has the for some people have not done residency. How's the atmosphere like in a residency program, especially in an internal medicine program? Is it very stiff? Describe an everyday kind of life for a resident, Dr. Janet. Is it
I think to
very
answer that question,
official? There's no time
honestly,
to say hi, hello. Everybody's running with their books.
that's not true. It's not that bad. I mean, I've not been to like malignant programs. I think that question is very program specific.
Right.
But if I were to talk about my program and neighboring programs where my friends are, it's guys, relax. It's not that serious. Typical day in my program. For honestly, actually, for reasons that we are aware of, very positive culture from the receptionist to the teaching, non-teaching staff. You walk into the res lounge, you have what? Overnight team. You say hi to them, like Endurance said. Always say hi to people. I mean, that's our culture anyway. Some of them will answer you, some of them will not. You need to also understand, in a way, it's also, part of the culture shock. In Nigeria, it's like when you say hi to people, you expect them to answer. Actually, these people know it's not a right. Like, don't feel entitled, and don't go into your shell because you were very friendly with somebody and they just gave you the stone face. People are different. Like, appreciate different personality.
That
But a
means there's a
typical
cultural, that means there's a
oh,
cultural perspective to this whole thing.
absolutely, absolutely.
Hmm.
And I'm saying this because unlike Endurance, who was the only Nigerian, we actually two in my program. So anytime something like that happens, we've called each other like, she said hi to senior, this one, I don't know. She was just looking at me. We start to get so bored. She doesn't like me. It's sometimes it's not that serious. You meet the overnight team, you say hi to them, you ask them simple question. How was the night? Hope it wasn't too stressful. Sometimes you know how stressful it is because on the board they've admitted like 10, 12 people overnight, right? Oh, you guys admitted a lot of people. I hope it wasn't too stressful. Things like that. And then when they are talking to you, they are signing out to you. There are times you would have questions. Try as much as possible not to interrupt too much. You don't want to come across as somebody who is how do I
Impo-
say it? It's almost
you-
like you are nitpicking,
Yeah.
what they did overnight. You can have questions because at the end of the day, that will be your patient panel. I get that. But try to listen to what they are signing out to you. If you have questions, be like, oh, you mentioned this. I wrote it down. I didn't want to interrupt you. How did you guys go about this? What are the things I need to look out for? As soon as you're done signing out, that's the time you have with, your senior. Say hi to your senior and be like, is there anything you need me to do before I start a chat review? You are just trying to let them know that I am present. I am present. I'm here. Do not ignore me. Not the one that you will collect sign out. You go and sit down in one corner. I understand that you're timid. I understand that you're a shy person. You're not the most jovial person. But as much as I hate to say it, they are taking down notes. they're actually taking down notes. So you want to make like the team you're working with, your senior, the med students, your colleague. Oh, that's true. I mean, it depends on the program. Your co-resident, right? You want them to know that you're present, you are part of the team. Yes, you have your patient panel, but you are okay taking off load as need be, obviously, without having to aggressively displease yourself as well. So I would say, yeah, for the most part, that's what it looks like, at least in my program. And you walk through the day and, you go home.
Apart from Andreas, let's pitch you from this way. Pitch it from this way. Apart from the cultural barriers, there's also something about language, uh, the way we
Yeah.
speak that also affects, especially people who didn't train in the US. Look,
Yeah.
the young fresh graduates are very fast. They're just answering the questions. They're on their toes. And many of us, some of us, not even many, are graduates like 5 years ago. Okay, so what are you going to do for this patient? This patient is. Have you also noticed that as?
So I was gonna come to that point, but I was going to also piggyback on what Janet had said. So some people, when you greet them, they don't answer you. Actually, most of the time, they don't even know what you're saying. They don't even expect you to greet them.
Sure.
That's why. And then, so some of them are deaf. Some of them are, these people live so old. They're like 70 years and they're moving around like young people. They're not hearing what you're saying, man, for the most part. So you just understand that part. Um, to your question about communication, I was going to talk about communication explicitly because when, as physicians, with whatever specialty you are doing, it's by far the most important skill you want to have. And if anybody is listening to me, you need to write it down. The most important skill I need to have is communication. There is no skill. I know people get worked up about their IT, writing IT and IT score. All those stuff don't mean anything. Your communication is the most important skill. And what do I mean by communication? Let's start from the beginning. Your accent. Now, you speak fluent English, or you think so, but most people don't understand us. And that's because when we speak, we don't enunciate our words, we don't pause enough, and sometimes our tongue is so fast it rolls over, right? So they don't understand us as fluently as we think. And that also happened to me. So I got a feedback from my associate program director, and the feedback was you need to slow down when
Slow
you
down.
talk. You
Slow
need
down.
to enunciate
I
your
also got that
words
feedback. Yeah.
and be able to talk to your patient. And actually, when I translated this practice into seeing patients, talking with the nurses, talking with the patient's relative, in the last 3 years, there has never been a time I am on the floor that they will not give me like patient faces awards because one patient said, "Oh my goodness, that doctor was so fantastic," back to back to back, because I was able to communicate. They can hear me. 70% of the time, what I see with my interns, when I walk into the room with my interns and they're taking history, I can clearly see that the nurses, the patient relative do not understand what's happening. I can see it like very obviously, and they're not necessarily Nigerians. They're Indians. They
They're
are
lost.
Pakistanis. They are the patient. The doctors are not. They're not Nigerians. They're like Pakistanis or Indians or even any other country outside the US. It's an IMG thing. As soon as you have an accent, you have to understand the problem with your communication and try to fix that. So what I want you guys to do is start speaking more, start enunciating your words more, start taking more pauses, and try to check with your patients if they understand what you are doing, what you are saying. Because that's what all we do on the floor. We talk with the patient, we talk with the patient's family, we talk with the nurses, we talk with the social manager, we talk with the attendants, we talk with our colleagues. It's just talk, 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 talk. The whole work is just talk.
All communication, right?
Yeah. So that's the most important skill you need to learn.
Wow. Once again, this is it's just like 5 minutes, and I feel I've heard a lot. Even me, that is second year PGY, is like growing in knowledge every day when I listen to you guys speak. Once again, this is IMG Research Academy, now Global Research Initiative. Topic today is on how to excel when you eventually match. I know there's a stage of hey, can I get into residency? Can I get into residency? Now that you're in residency, how do you excel? And we've in the last 5 or 10 minutes thereabout, we've addressed or we've enumerated or highlighted some of the common problems that most people who get into residency are probably going to face. We've talked about language, culture, um, confidence, knowledge gap, and all those whole stuff. So we're going to like dive into more details in each one of this this things that we're enumerated. And there are so many others as they begin to address us and as the discussion begins to flow, they'll highlight more of them. Dr. Janet, let's talk about professionalism. Professionalism is something um, that you're expected to grow with in residency: professionalism in communication, professionalism, mannerism, professionalism in the way you talk, the way you address, the way you dress people, professionalism on punctuality, whatever dimension of professionalism that you have seen, common problems, and how can a new resident improve? What are the tidbits, like real life scenarios that you recommend?
Absolutely. So one thing I always tell my interns, professionalism is not about being perfect. You just want to be reliable. You want to be trustworthy, respectful, and rooted in purpose, even when nobody is watching. That's how I see professionalism. And very important for you guys to know that it is part of the ACGME core competency. So when you guys start residency, oh yeah, your medical knowledge, the application of medical knowledge, communication, patient care, those are the different core competency under ACGME. Professionalism is one of them, right? Under professionalism, you're expected to be accountable. You have to be accountable. So exactly what Endurance said, like when you have your patient, you are not only treating the patient, you're teaching the patient because they are part of the team. The families are there, right? You have to be accounted, you have to account for your patient, if that makes sense. Respect is very important. Down to the non-teaching staff. I heard a lot of scary stories before I started residency about nurses. I can confidently tell you one of the biggest strides I've made in residency came from the enormous knowledge base that I learned
That they
from
have.
the nurses.
Yeah.
The nurses are very important. We are
Yeah.
looking at people, they've been doing these things for years. There are things that are not in the textbook. So respect your colleagues. One example of respect is actually you being on day shift and coming in late. You are trying to tell them that you people that worked night shift, I don't respect you. I don't respect your time. And also the other way around. I'm just saying, the respect. When I say respect, I know Nigerians is to bow down. Nobody asks you for that. You don't need all of that. But I learned quickly that even if you're on night shift and you are running late, make sure your senior knows. Don't come in like, oh, I'm just 5 minutes late. To you, it's 5 minutes. We always do Nigerian time. This is not the time to do that. Emotional maturity is also a very, 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 very important one. And it comes under professionalism. We all say we want feedback. You are seeking feedback. How do you take the feedback without ego? Integrity is very important. You have to be humble. I don't know how to say Misha. Maybe endurance will be able to word it differently. Some people are very boisterous. Some people are, like you said, like overconfident. But there's a way that you can be professional while being very confident, right? There's a way you can be humble as well while being very confident. Compassion. All these things are different things. You are having the worst day. Everybody is going to, if some people tell you what they are going through residency, you will be so surprised. That does not give you the leeway to be rude to people. It doesn't give you the leeway to be rude to patients, teaching staff, non-teaching staff. My ladies out there, don't worry, they will call you a nurse. Don't worry. It does not matter whether you wear white coat or not. I've tried the white coat method. They tell I'm somebody who I love fashion, so I'm always very well dressed. Good morning. My name is Dr. Janet Omole. I'll be your doctor. As you are walking at, they're asking you, so
Who's the
nurse,
doctor?
when will you bring my medication? I'm like,
Right.
bruh, I just introduced myself to you as a doctor. That does not give you the leeway to, be rude. And when I say rude, when we are talking about professionalism, a lot of people are always on their best behavior in 10 years. You start to see the deviation from professionalism when you start to get more confident in this medicine we're talking about, especially when they are transitioning into second year or even third year. So just remember, it's one of the ACGME requirements, it's one of the core competency. Your program is marking you, they are scoring you for it. And we actually had one of our residents rusticated on it because of issues with profession. Obviously, I can't share exactly what she did, but I just want you guys to know
I
that.
just saw a
So
comment from Lilia. No eye rolling. Like
no, yeah,
that is
no,
so funny.
yeah. If you, and we Nigerians, our face speaks a lot. Let me tell you something that helps me because my face speaks a lot. Mask, wear mask. Oh, it's no longer COVID era. Wear that mask because my face speaks. When my intern is, I'm already looking like you can tell. So mask saves me a lot. So if you are the type that your face speaks before your mouth, please wear mask. I beg. But yeah,
An area where we actually really need a lot of residents to be very, upbeat. Almost every area, but we're still dwelling on professionalism. And there, as we've heard Dr. Janet's, any echoes from what she said and additions?
Yeah, I think to her point, she has a very, strong point. Especially, I've seen a lot of IMGs get angry that, oh, this person called me a nurse, or this person didn't add doctor to my name. You know, people get very, I mean, it's something we'll talk about on another day. I think that a couple of us, when we leave Nigeria, or not only Nigeria, when we leave our country and then we come to the US, there are some things that we didn't take as a big deal when we were outside, when we're in our home country. And then suddenly we're taking them as a big deal in the US. Because like one of my colleagues got really, really mad because the nurse didn't call her Dr. X. Anyways, I mean, yes, as an African, as a Nigerian man, you will see a lot of people that would think that you are the maintenance. You would think that some people would think that you are the guy that is serving food. They will say, "Oh, I get my food," or they'll ask you, "Are you the respiratory therapist?" That kind of stuff. You'll be on word code. Don't worry. With your word code, they'll still ask you. For sometimes even the nurses will ask you. Like Missouri is like 99%,
Yeah.
95% white. They'll ask you. But that's not the
Okay.
point. You can't get peace. You
Yeah,
just
sorry
smile
to
at them.
interrupt you. Something that is also very common is as a resident, they will think you're not a real doctor, that you're a doctor in training or a student in training. They often, especially in clinic, they will say, these guys are not real doctors. I want to see the real doctor. Yeah, go ahead, Endurance. I didn't mean to.
Yeah,
So
I
it's
mean, my
very
experience
common.
was, yeah. So like what Jenna said, the experience, your experience is very, very different depending on the program you are in. That's one. Then even within the same program, different residents have extremely different experiences. As in, you can be in the same program. One person is in heaven, the other person is just in, hell. The same
absolutely.
program. It it's all about you. And it boils down to the same things we're talking about, those pillars. And actually, I can just go through them at the end of this meeting. I'll just go through them and just summarize them in like 6 points. These are the crucial points. Like, because number one, like Janet said, you have to have the nurses on your side. There is no ifs, there's no buts. The nurses must be on your side. If you have the nurses, residency is autopilot for you. 70% is done,
Yep.
and then the next one is just, medical knowledge. Also, other things that are left are
We'll talk
just small
about
things.
medical
But
knowledge.
yeah, we'll talk about those things.
Yeah, we'll get
But
there.
yes, yeah, I completely agree with what Jenna said.
I have a very quick example.
Sure.
I just remembered, and I want to share this because, unfortunately, this resident is actually going through it. It's on serving punishment. Clinic. We have one of our second year resident who got the opportunity of taking care of a patient transitioning transgender. Ha! Tell me why this uncle was preaching the gospel to the patient. That's part of professionalism. It's none of your business. That's not why the patient came there, right? So I'm sure he had great intentions, but there's time and place for things. Don't do all that. Sometimes we carry this our religion stuff. Like, I understand it went from probing the patient, asking more questions. I get that part. But when you start to go into, God doesn't want this, you don't want to do that. And obviously the patient reported to the charge nurse. They took up the case, and the resident is going through it now. So I definitely agree with what Endurance said as well.
We're moving on to other areas of residency. Again, it's a very relaxed conversation. But before I move on, there's something that's always very, I need you guys to, shine light on. Who do I impress in residency? The program director, co-residents, myself. Do I even need to impress anybody? What's your take on it? Let's start from Endurance.
Yeah, I think that's a very fantastic question. And yes, most
Because
people that get
it's
most people
a
that get
it's
into
a
residency,
it's an urge that you're gonna get. Let me kill it. Let me, impress this
yes,
person. Like, okay.
I would like to break it down into a few phases. There is the phase of getting, settling in, and then there's the phase of impressing. When you are as an intern, of course you want to impress. And it's not because you are like buttering up to people, it's because your letter of recommendations when you want to get a job, you know, of course, these people have given you a chance to come and train. You're supposed to let them know that, oh, I am, I'm here. I'm that thing I put on my CV. That's what I am. You know, I am fantastic in terms of patient care. I'm fantastic in terms of interpersonal skills and blah blah blah. But the point is, yes, you want to impress. You want to impress your patients. Most importantly, you want to impress yourself, and by so doing, you will impress other people around you. But that is not the goal in the first phase. The early phase is to settle into the program. In your first 2 months, do not go and try to impress anybody. The people who try to impress very early on often stumble, because you are talking a lot, because you are trying to do the things you're not familiar with. We begin to see your flaws very quickly. So in the first few months, let's say the first 3 months, you just want to nod your head and smile. They will tell you what to do. You ask questions, nod your head and move. Don't go and be moving stuff. We're Nigerians, we like to move stuff, Abi. Uh-huh. Me, I was in Nigeria too. I like to move stuff. No, 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 don't move stuff. In the first 3 months, your job
For
is to
those who are
settle in.
non-Nigerians and are listening, us move stuff is, how do you define move stuff? Because that's like a
So
term
yes,
and there's
forgive
so
me for
many
that.
non-Nigerians
So
that are listening to us currently.
forgive me for that.
Yeah.
So when you get in your program, you don't want to sound like you are a smart ass. You don't want to, they ask a question on rounds and you are trying to dish out the answers on day one. Don't do that. I don't know if you've read the book of the 48 Laws of Power. Never outshine the master. At least
Very
not
good.
in the first 3 months.
Yep.
Nobody cares of your knowledge. I want to reassure you that I do not care about your knowledge. What I care about is how you are trying to find your footing in this program. That's your first 3 months. Then after that, you can now start your scholar stuff. And to be very honest with you, when you are not trying to impress people, that is when they are mostly impressed with you. When you try to impress people, they are not impressed with you because they know you're trying to impress them, right? So you want to resist that urge at least in the first few months. In the first few months, you just want to learn a couple of things. Number one thing you want to learn in the first month is you want to understand the unspoken rules. Every program, every program have rules that nobody speaks about, that nobody talks about. Like you want to understand who is the most influential person here. You want to understand when am I supposed to submit my notes. You want to understand, how am I supposed to present my patients to my attendings? Because every attending has different ways they want to
What is the structure of the notes?
what's the structure of the notes. You want to understand these things that are very subtle and not written anywhere. You want to come early. Like there's one of our PGY1. He's a Zimbabwean guy. He comes. We start 7 o'clock in the morning on the floors. He comes 6:30 in the morning. You can already tell that. Of course, he doesn't. I'm impressed. He doesn't have to move stuff. He doesn't have to say. He doesn't have to act like a smart ass. He comes 6:30, so I'm already automatically impressed. So from day one, you want to show up know what you are doing, ask the right questions, listen to the non-verbal cues in the program, and understand the chemistry of the program. Some programs like outlandish residents, some programs like a certain kind of resident, some programs absolutely hate that kind of resident. You want to just settle down and know your program, because regardless of what we say here, we are talking from the perspective of our own program. You want to use the first 2-3 months to understand your program before you start trying to, show them how fantastic you are.
I know your program, both of you, your programs are unique, but by and large, from communicating with a lot of residents, like for me, leading this group, I think most programs run on the same fuel or on the same gas. Like it's almost similar, one or two differences. Uh, Riding on that way, professionalism, impressions, teamwork. Teamwork is, another area where we see deficiencies. Who who would you define as a good team player? Before you answer that, Dr. Janet, I also sent you something on WhatsApp, and also Dr. Endurance. So maybe you could take a look at it at your slow time. But let's talk about teamwork, an essential aspect of medical practice and also residency. How would you define a good team player? What is a good team player?
I feel like before we even get to the definition of who a good team player is, I think we need to understand the goal.
Okay.
Nobody is competing with you. If you see residency, you see your co-residents as, I mean, maybe you can call it subtle or benign competition. At least that's what I would hope it is. But if you are seeing it as all these, you know how sometimes we IMGs can be. The chances of you being a good team player is slimmer. You are supposed to collaborate. So in the effort of collaborating, that's what is going to make you a good team player. For me, a good team player, like I said before, you have to be able to, they need to be able to rely on you, right? They need to be able to rely on you. There's no way people would trust you with information, with patient care, whether it's your own patient population, your patient panel, or theirs, if you're not reliable, right? You have to be a collaborator. You have to be humble also. And I think I'm one of those people who is very big on energy. When my interns first come for rotation, like Endurance said, I was going to piggyback on what he said. He said something about show up. I always tell my interns, one of the ways you can be a good team player is not only when you show up, you have to show up with good attitude. It doesn't stop by showing up, because you can show up, but then your attitude is nasty. Medical students don't feel comfortable talking to you. They don't feel comfortable asking you questions. Even the senior self is looking at you sideways, like, am I supposed to correct you or not? Because the moment they correct you, you're already doing face somehow. So for me, when I think about an intern who is a good team player, this is an intern who knows part of me being a good team player is showing up early to work. Now, if you are one of those people that is very anxious before rounds, you need more time. Yeah, like Endurance said, like his colleague, if you want to show up even before then, oh yeah, that's fine. But show up to work. Be nice and approachable to people. Be reliable. It comes from the little task. When you say you will do something, do it. And please don't lie. Don't lie. It always comes back to bite you in your ass. Do not lie. So I think those are the
Yeah,
characteristics
do
of
not lie.
what
Did you ask the person about smoking and you just assume the person smokes? And
exactly things
then you
like
just say,
that.
yes, I did. He's a smoker. And you say, how many years did he smoke? And you said, oh, he smoked for 30 years. And you just assume it's 30 years. And then we get to the patient's bed and say, do you smoke? He said, no, I never smoked.
That happens a lot.
And
That
then
happens a lot.
they begin to lose confidence in the information that
Exactly.
you give them. Did you
Yeah.
find out what pharmacy the patient uses? Oh, yes, he uses CVS. What pharmacy do you use? Where do I send your medication? I need to send it to Publix. And you'll be like, but he told me CVS. And then the attending begins to look at you. Reliability. I'm just speaking back on what Janet,
Yeah.
be as truthful as possible. If you did, oh, I did
Truthful.
not do it, I could just go get it done and just go get it done. Dr. Endurance, team player. There are a lot of comments on the group I'm going to take all of them. Thank you, Dr. Nama. Nama, I hope I pronounced your name well. I see you, Dr. Lillian. We're going to say all those. I'm going to read them out, but let me give Endurance slot on this. How does an
Yeah,
intern
I mean, I think Janet has
function as an
already
intern?
dissected what a team player is. What a team player is showing up, having the right attitude, you know, asking for feedback and taking the feedback.
Let me stop you
Um,
at feedback, because I've seen this scenario play out. Should an intern seek feedback? How frequently? When? And Dr. Janet, feel free to also, chime in at any time in this conversation.
uh, so when you see a patient as an intern, when you go in and the first thing is you want to ask, how do you want it to be done? So, what's the team player? The day you show up or the day before you show up, you can approach your senior and say, "Oh, I'm rotating with you. We have this whole 1 month rotation on the floor. What are the things you'll expect me to be doing?" And
Expectations.
you ask for expectations, and then they'll let you know what they want, or they may even meet you and tell you what the expectations are, right? And so on day one, you want to take history. That's your first day. You ask, how many minutes do you want me to take? I don't want to stay longer. You just ask questions that you don't have to ask minutes, but you have to ask questions that you don't know exactly, so that you are working with a sense of decorum. Because you don't want to be in the room with your senior. You are blowing 30 minutes. The senior is looking at you. You want to have your senior guide you so that you are on point from day one. Now, when you leave the room after seeing the patient,
I'll hold
what
your thoughts there. I'll come back to Janet on because there a lot of people don't know this structure. It took me a while to understand that there's a senior, junior, intern structure, especially for us that have practiced before. So, Janet, you're going to probably describe the typical, structure in a typical residency, the junior, intern, attending, kind of hierarchy of cadre and what roles they play. Go on, Dr. Endurance.
So you want to, when you've seen the patient or when you've done a task, whatever the task is, just meet your senior and ask, how did I do? What do you think I can improve? And just 2, 3 questions. And then they will give you a feedback. They may say, oh, let's wait, I'll give you feedback down the road. But you want to ask those questions. You want to get those conversations out of the way so that the quicker the faster you can, adjust your approach and the better you will be. Because if you wait till 2 weeks, 3 weeks, then you have lots of feedback. You might not be able to assimilate the feedbacks as quickly as you want, or so you want to get feedbacks in real time on the go. That's what you want to do. That's it. Then we'll now know that, okay, this person is well informed. This person has insights. That person is a potential great team player because they can identify when they need help. They can identify when they need feedback, when they need improvement. And that's what you need. You just need somebody that knows the limitations, knows what they need to improve, and go and fishes for those information. And that's a great team player.
The typical residency structure, Dr. Janet. Intern, second year.
Yeah, so exactly, it's hierarchy. Depending on the program now depends on
The flexibilities, yeah.
the flexibility and what that hierarchy looks like. There's a horizontal hierarchy, there's a vertical hierarchy. For my program, the way they make us comfortable, there's hierarchy, but it's on the leveled ground, such that from med student to intern to senior year, it makes it very comfortable for you to approach the attendants. But exactly what you said, you have the medical students. They are there to try to figure out their life, things they need to do, learn how to take history and all of that. You as the intern, you are the engine of the team. Sometimes I even call it you are the laborer of the team, because at the end of the day, you are above the med student, obviously, but also not that to the level of the senior. The seniors are like the managers. So you are the engine of the team. You will also take history. You would take care of the patients, let them know of what your plan is, which will either be seconded by your senior, or they would, put you through and stuff. You as the senior, of which, I mean, that's not what we're talking about it, but as a senior also, they have a role, which is basically, we call them the managers in my own program. They are the manager of the team, which is basically, they kind of oversee the med student, but also you, that you are the intern. And of course, each and every one of us, we all answer to the attending. That's the big boss. That's the oga at the top. So it's like, in terms of hierarchy, is med student, intern, senior, and also the attendant. Now, because the purpose of this forum is talking about intern, be coachable. Let your senior feel like it's not war to teach you, to correct you, to give you feedback. At the same time, don't be selfish with knowledge. You are supposed to, what's that word we always say? Is it push forward? How do we always say it? Pay forward. Yeah, pay it forward. And part of paying it forward is you teaching the medical students. I will give you a typical example. I was the ACP resident of Illinois, year 2023 to 2024. Came as a shocker to me, because like Endurance said,
Congratulations
like
from all of
Endurance
us.
said, I wasn't trying to impress anybody.
Just being yourself.
If at all I was competing with anybody, it was myself. Again, typical Nigerian, we're very self-critical. I wasn't trying to impress anybody. But when they were reading the folder as to why they gave me that award, ladies and gentlemen, it's not about just being smart. It was things that the attendants said, so enthusiastic, always wanting to learn, but also what the med student said, always willing to teach. Now, teaching is not for everybody. I understand that. If you love to teach, residency is actually a very good platform for you, right? So I owned on to that skill, in the sense that if I learned something from the attending or from the senior, I made sure to try to break it in simpler terms to my med students, right? I guess that's also part of being a team player, to be honest with you. But yeah, that's typically how the structure goes. So if you look at it, you kind of answer to some people, which is going to be the seniors and of course the attending. But at the same time, you are like also your own, I would call it, you're a boss too. You're a boss. But that's where the med students come to you, asking you questions. You try to guide them through. So that's typically the way the structure is, at least in my program. I don't know if it's the
Yeah.
same way.
Endurance, is it different from your program?
You're muted.
Endurance, can you hear me? You're muted. Well, while Endurance unmutes
Okay.
himself. Yeah, we can hear you now.
Yes, sorry about that. So I completely agree with Janet. It's just you, it's how you trying forcing yourself to impress people is definitely not the way, especially not within the first 3 months. In the first 3 months, you just want to settle in. You just want to, you just want to get in the program, understand the non-verbal cues, and then try to work on your efficiency. That's what you want to do. You don't want to go around impressing people, because at the end of the day, you might be impressing people that don't even, people that you shouldn't be impressing, people that don't have shared the same goals, and
Right.
just don't try to impress anybody in the first few months. No, do not do that.
Moving forward. Um, Once again, this is IMG Research Academy, now Global Research Initiative. We're talking on how to become a better resident, especially when you resume in July. For those who marched, about 158 members of foreign trained residents who belong to different communities that we belong to march into residency, and we've been addressing one aspect of residency and interns life. Now we're going to step up a little bit to time management. As an intern, from my experience, a lot of things are thrown at you at the same time. Go see this patient, write the note, finish the note, do your presentation. It's a lot. And then chief residents, I don't mean you or the residents or the senior residents, they cross their leg, probably playing on their laptop or maybe researching or doing something more, not necessarily playing on their laptop. But to us, when we were interns, we thought they were just, relaxing in their seat while they're throwing us. Have you talked to the case manager? Go to the ED, find out there's a patient there. And then it's very frustrating for some interns who don't have this expectation and know how to manage time. It could throw them off balance, it could make them irritable, it could make their stress levels go high. Talk a little bit about time management, what is expected. Let's go into more detail, practical examples. Let's start from the Janet.
Time management. This one, you just took me back memory lane. I
Yeah.
struggled. I struggled. I struggled. You know how during interview they ask you what are your weaknesses and you say, sometimes I'm too detailed oriented, and then they ask you what are you doing to work on it. You give them, all those things we
Well,
said.
yeah, interview rehearsed answers.
Okay, this is really, yeah, residency will test you if you are a very detailed oriented person and you don't really know how to work with time. I think one of the biggest things that takes away your time is chat reviewing. Dr. Eddie, this one is a little bit, I mean, we will give, our advice, but I feel like this is just one of those things that you have to go through it, right? Because I remember learning this or hearing
That's
this also
review.
from people before me. So with chat review, like Endurance was saying, right? The chemistry and all of that is part of the logistics. I always say you have to have a structure to your chat reviewing. Until you have a structure to chat review, I'm telling you, 30 minutes, 45 minutes, you're still chat reviewing one
Yeah,
patient.
you're
You
looking at
have
the things that are not even necessary.
the things that are not
Yeah.
necessary, right? So in my program, one of the ways we were able to at least tackle that or prepare our interns for it is we have something called an intern boot camp the first month when they come. And that's one of the things we talk about where we tell them about structure. But even before then, if you know you are the type of person that is slow to learn, personally for me, I am not a computer guru. EMR is not a thing that I really know much. I used to show up. So our rounds, our sign out starts at 6:30. I'm in the hospital 5:30. Simply because I know myself. Now, with the structure to chat review is basically saying when I sit down, they've signed out the patient to me. This is the same flow. This is the same pattern I'm using to look into this patient. I'm checking my vitals first. I'm going straight to the labs. As soon as I'm done with the labs, I want to see what imagings were gotten. Oh, I've checked what images were gotten. Okay, now let me go to the ED note and see, one or two things that they said. Okay, now let me go to the overnight team and see one or two things they said. Okay, I've gotten like the picture of what I want. Are there imaging I need to compare? Are there labs I need to compare? Okay, I will note that down. I'm already creating my differential diagnosis already in that spot. You have to have a structure. If you do it like that on one patient and then the next patient, you start with ED notes or you are going to waste your time. Don't let chart review own you. Like they always say, you will even learn more about your patient than the EMR system. The things that the patient will tell you, it's actually even much more important. The things you are able to see, because that's also where, we find out some interns are lying because what? They didn't manage their time enough to go see the patient. So they will tell you they saw the patient. Yeah, because the patient has history of heart failure. Yeah, bilateral pitting edema. When in reality, patient has just one leg.
Right. Right. Does the patient
So
have us bed ulcers? You say no, but the patient actually really
Exactly.
had bed
So
ulcers.
you have to have structure to your chat review. You are not an island. They don't expect you to know it, right? Especially for we IMGs, it's something we struggle with. Like Endurance was saying, when you start in a team, let your senior know. That's one thing I did with all of my seniors. I told them, I said, I want to learn. Teach me. Whatever worked for you, It might not necessarily work for me, right? But at least I want the basics. I said, chart reviewing is not my forte. Please tell me how I'm supposed to go about it. And the reason why I'm expanding so much on this is that's really what takes the most of your time on. To be honest with you, that's what takes most of your time. Because if you are able to chart review, bam, 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 bam. Again, chart review does not mean you know every single detail about the patient. You are not expected to know every single, because you are also working with time. You have 10 patients to see. Only one patient, you are spending 40 minutes to chart review. You will notice that the other patient, you don't really know much about them. That's one. Then you need to start prioritizing which patients are really the sick one versus which one are not the sick one. Which one do I really need to spend most time with versus which one do I need to quickly do a chit chat, be fast with my physical exam and stuff. And I say that because you also have to leave that space that some patients are very chatty. That's another thing. And
Patients
as an
really
intern,
can
you
talk.
are just starting. You don't want to tell them, madam, this your insurance is honestly right now is not really the bone of contention. You know what I mean? Although
Right.
with time you guys will know what tricks it is. One for us, we have an Alcatel. I don't know if you guys have Alcatel endurance. So I just press the volume button. The thing will do. I'm like, hello? Oh, okay. Okay, I'll be there right away. That one we'll talk about later. But for me, I would say time management again, come early if you have to come early. People are different. People are different. Some people are very good with EMR. Some people they already knew how to work Epic. Me, I didn't know how to. Come early, prioritize your task, chart review, find a structure to chart review. You have to find a structure to chart review. And I think, yeah. And yeah, I would
What
say
are,
ask
what are,
questions too.
what are areas of time management endurance? Are there tools that you could recommend that may probably help? These days is days of AI. What are the AI policies that could help you, reduce or crunch your time, especially managing time, seeing patients? Are there common tools or shortcuts or tricks that you could, in addition to what Janet has said?
That's a good question because my program has been doing this pilot program where you go into the patient's room and you're talking with the patient and you have something on an app in your phone and it's recording and it just forms a note for you and even a plan, and then you have to just edit. But that AI has failed woefully, and we're back to chat reviewing like normal. So yes, you chat review is by far the most time you spend in the hospital. And actually, we developed a system. We actually developed two approaches to chat review. One, don't chat review, just go and see the patient because that's the way you did it in Nigeria. And then when you're done seeing the patient, go and chat review. But then when you go back to chat review, you look for less information because when you were chat reviewing, you're looking for every single thing. But now that you're not chat reviewing, you now know what to look for. That's how we started in. So the first step, just go and see the patient. Patient comes to the floor, go and see the patient. You get your sign outs, go and see the patient. And then come back and chat review. You see the patient for like 15 minutes, come back, chat review, 15 minutes. You are done seeing the patient. That's the first one approach you can do. The other approach is while you are chat reviewing, you can dictate the notes. So as you are chat reviewing, you just dictate the notes. So as you're like, oh, Miss X is a 45-year-old female who has past medical history of diabetes mellitus and hypertension. She presented today with complaints of chest pain in the ED. In the ED, her family had said that she had this chest pain for the past 1 week. Her vitals were XYZ. Echo from last month was this. The chest X-ray in the ED showed this. She was given ceftriaxone and zosine. She was admitted to the medical floor. Period. I'm done with this, right? Then I write the problem list: chest pain, diabetes mellitus. I'm done. I just go and see the patient. So we actually put this. We teach our interns the way to write the notes and the way to chat review. It helps them. You can ask your seniors to teach you because if you learn it on your own, you're going to use like I don't know 3 months to learn it. So just ask your senior; they'll just teach you bam 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 bam, and it'll be so easy if someone
Amazing.
teaches you. Yeah.
Amazing. As we roll into the second quarter or probably the last quarter of this conversation, so we could make things live. But before then, let's talk about medical knowledge because that's like the center focus of residency. That's like the whole thing. Are there like expectations? How do you study? How do you even have time to study? how do you learn? How do you grow? There are various models and various programs again, but we're just trying to, pick a mean and also tell us what happens, especially in your program, how you expect it to improve, how do you measure your improvement? Does the ITE count? What does it even mean? So it's a free talk. Janet, Endurance, any of you can approach it, and the other person will complement the other person.
Endurance, you can go, I can compliment.
And I think that the IT doesn't count for anything, especially in my program. And I'll say this because, so what I think residency is about is demonstrating some skills that I would say is soft skills. Residency is mostly about soft skills, not about strong, hard skills. And the hard skills are the skills that can be taught. The soft skills are the skills that they can be taught, but they are more subtle. They are more difficult to tease. For example, emotional intelligence. People that have cultural sensitivity. For like that guy that was preaching to someone who was, transitioning. There's some things that you cannot teach. Residency is more focused on those things because my program also said that if a person has a problem, usually is a person problem, and that cannot be fixed. They're mostly worried about your scores while they count, but they don't hold them in that high esteem as much as they hold a patient, someone who might not be a fantastic, scorer, but a patient is writing notes to the program. Patients actually write notes. I met Dr. X and he was so fantastic to me. And then they send it to your program because your address, on the website is actually your program. So you will come and see card notes from a patient to you. They value those things by far. If your score is 299, it's your business. If patients say that you have a problem, your score doesn't mean anything. So I think that's the thing, because when I was in Nigeria, I was also the chief resident in Nigeria. The only thing that was counted for me to be chief resident was my scholarly activity, was just being a scholar, me moving stuff on word round. That's all you need to do in Nigeria to be called a scholar. It counts for nothing here, man. Every single person has some form of knowledge. The disparity is not too much. You might know but most people are still here. So there's no real difference. The difference in knowledge will not result in a patient mortality, right? So that's your scholarly activity. While it is fantastic, it's supposed to complement other things. It's not supposed to be a standalone thing, especially for us Nigerians. The way your communication, your patient skills, your nursing skills. One of the biggest things that worked for me during residency was just the nurses absolutely giving great feedback to my program. The nurses from day one, we love endurance, blah, 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 blah. That has been the way, that was how I ruled my residency. Nurses loved me, and I love them too, because they are a huge part of patient care. They are a huge part, so that's one. So no, your medical knowledge, while your medical knowledge is good and it's impressive, it counts for almost nothing. Okay. And I would say this because we are about to hand over to our next chief resident, and one of the residents in the program, he has 100 percentile on IT, but he's not the chief resident. So it doesn't count for anything. You say it may impress them, just transiently. They might be impressed for a few weeks, but ultimately, what will become your brand, what will become your reputation as a physician, is the totality of who you are.
Dr. Janet, academic growth, academic content of residency program, any tips?
So for me, this one, I don't know, Endurance might not even agree with me on this one. I would say, how they always say, enjoy yourself, and it's true, enjoy yourself now. Residency is not easy. I don't care how much work experience you have in the different sector you've worked. There's just something about residency that is different. I can also explain it. I mean, I've been in this country too for 7 years plus, and I worked as a DSP, CNA, name it. Residency was it was a little bit different for me in terms of academic excellence. And I wanted to touch base a little bit about medical knowledge because it's something I'm very passionate about speaking. For my program, IT kind of mattered. they make it look like it did not matter, but it mattered in a way. And what do I mean by that? Now, like Endurance said, again, be more focused on logistics, how you are learning like your day-to-day, like structuring your mental framework, knowing what and what not to look for in a patient, knowing how to start determining which patient is sick versus non-sick. So, your level of patient acuity is there. Yes, I get that. But you see that medical knowledge, in a way, I would say prioritize the bread and butter things. Try to learn those things. I will tell you one of the mistakes.
Everyday things, yeah.
Yes, the everyday things, those things. Try to know something about it. I will tell you one mistake I made that made one of the chief residents pulled me to the side. There was a day he saw me. I sat down with Echo. Endurance will know what I'm talking about. If you people, when you look at Echo results, if you scroll all the way, you will see where they are talking about parameters. I sat down with EA ratio, and I'm sure Endurance knows what I'm talking about. EA ratio, LVTI. I was writing it down. And the chief resident one day came to me. He was like, sorry, what are you doing? And I was like, oh, it's just that, sometimes I thought I heard the cardiology fellow was saying some things about this patient. And he told me right there and there. He said, can you confidently tell me you know how to manage pneumonia? Can you confidently tell me that you know how to manage pancreatitis?
All right. Do you know the
What
dose
if,
of Tylenol?
exactly, like those day-to-day
Very
stuff,
simple stuff.
that's really what it
Yeah.
is about. You see those other things. With time, if you are interested in it, you will learn it. Again, for me, I am very self-critical. Before I started residency, I would say a week before I started residency, I went through the bread and butter cases. Did that prepare me for the transition? Not necessarily. It's just a very steep curve. I can't explain it. But at the same time, it kind of gave me a little bit of like rest of mind. I don't know how to explain it. It's like, because the last time I wrote step 3, only God knows, right? And I'm saying this because if you are the type of person that gets very emotional, that that when they realize you don't know stuff, it kind of makes you very self-critical, and we all know the dynamic. I'm that kind of person. I know it's a weak point of mine. I'm still learning to outgrow it. If you are that kind of person, I won't lie to you. I'll tell you, while you're learning the logistics and stuff, start to own on your medical knowledge. There are a lot of resources. There's up to date. If your program doesn't have up to date, there's Dynamedics. If your program doesn't have Dynamic, guys, please get Amboss. Amboss
Yeah.
is very good.
Yeah.
A
A
very
lot of
good tool.
resources. Even come on YouTube. Even in
Even
YouTube, you
YouTube.
see a lot of resources there.
Yes, you will see it there.
Listen
And
to podcasts
yeah, it's exactly podcast,
when you're
core IM
driving.
series, there's Copsiders. Guys, I'm telling you, there are a lot of resources. If you are not the type of person that likes to sit down with textbook, listen to podcasts. And I'm gonna send you a list, because I have a list I created. Send it
Thank you
to
so
everybody in
much.
the group. Start to listen to those things. So I won't lie to you. You need to start learning those things. Again, I would not advise this because it later beat me, which is we have mix-up questions. I'm not sure if Endurance, I don't know if your program, if you guys use mix-up too early on as a studying tool. If I see a patient, right? So if you have your patient panel, you know what you are treating the patient. Some is heart failure, all those pancreatitis stuff. I try to source out questions to look, okay, this is how this stuff looks.
Right.
Just try to start studying. Personally, for me, I studied the most as an intern. It gave me an amazing soft landing as a senior.
Right.
Did I know everything? Absolutely not. But when I tell you, it gave me a very soft landing, such that they're like, "Oh, Janet, as a second year, you will be the senior in the ICU." Like the first month in the ICU, and I was like, "Oh, no, no." They were like, "Oh, we know, you know, right?" I'm just saying this for those people who are very self-critical. Yes, you will need to learn the logistics and how things work, but you have to study. Medical knowledge is important. In my program, they started looking at IT because people who didn't do well in IT, they used to write their names down. Then they put you in this I mean, everything at the end of the day is to help you improve and stuff, but maybe because we have a lot of IMG faculty, we all know how this works. They start to judge you in a way based off of that. I'm just, but in terms of academic excellence in general, aside from medical knowledge, again, there's a difference between having the medical knowledge, there's a difference between that and translating that to your clinical medicine. Also, just because pancreatitis comes in, they come with abdominal pain. Be open-minded to any kind of
right.
Yes, I've had a pancreatitis that it was hiccups they came with. Hiccups. So basically, they had like pancreatic effusion that was irritating the diaphragm.
Very,
yeah.
very common differentials, CHF versus
All
COPD that
those things.
throws
I
all
will also
around
send
all the
something I
time.
used. Yeah, I will send you something that I used for my interns. It lists about 30 most common topics in patients in United States. They said that it's called the Pareto principle. They said if you at least know 70 to 80% of the management of these cases by the end of intern year, you'll be good to go. I will send that stuff to you as well.
Talking
So
about
I
good,
was,
go ahead.
yeah, so I would say medical, start to study. If you are the type of person that doesn't know how to study by yourself, find somebody, your co-resident, or maybe resident somewhere else. Try to start studying because I promise you, in 10 years seems so long. I promise you, it's going to go by so fast. And let's not even start talking about the anxiety. If you think you are anxious right now, there's a different level of anxiety that comes with, do I even know enough to be a senior? Oh, I'm going to be a senior, and now not only am I responsible for patient, but I'm responsible for med student, for interns, and also attending is expecting. Now, I'm not saying this thought process should overwhelm you now. No, exactly what Endurance said. Your first 3 months, just learn logistics. But as you're approaching senior year, start to own your medical knowledge. Learn from nurses, learn from anybody, from juniors. I've had a junior teach me EKG before. It's not my thing. And he was very good. He wants to do cardiology. I had him teach me that. So guys, please, I beg and beg and beg of you. I know it's something you guys will hear a lot. Yes, don't kill yourself. I agree. But at the same time, don't while away time also. Your medical knowledge, at some point, yes, you would need it. Yep.
I know there's a lot of people that want to ask questions. We encourage the open mic system. Just raise your hand by the group. If you don't know how to raise your hand, just say, hello, I want to ask a question, and then you go there. Let's go into other lighter things in residency. Very common. Now we're moving away from the hardcore stuff to the lighter thing. Very common office politics. When you step out of the room, it's some residents, it's like high school. Again, they're going to talk about you. They're going to criticize you. They don't like you. Sometimes you try to get close to someone and the person doesn't even want you to get close to the person. Your residents are your friends or they are not my friends. They like me. They don't like me. All those whole office politics are playing. My program director favors some people. He doesn't favor other people. You guys know what I'm talking about. Let's begin to piece them into pieces. How's the office politics like? I'm not going to say in your program, but what are the expectations? And then how does one buffer to handle this? And Terence, let's start from there.
Politics. Oh my goodness. I mean, there's always politics. There's always politics, right? There's no way we can. The whole program is built on politics. But I don't understand the question. What exactly is the question asking?
The
Please,
question is
can you
asking,
come
how
again?
do you handle it? Because it's going to come. It's going to come. You're going to hear that this person talked about me, or you're going to hear them talking about a resident or talking about a fellow, and you'll be tempted. Should I join this conversation? Should I not join? What should I do? Oh, is this how they are? Should I get frustrated? Should I not get frustrated? And then, oh, I worked so hard, and now they're telling me that he's so lazy. Wow, can you imagine that? And so on and so forth, all different types of office. And the other person who didn't even present as much as I did, they just said, "Oh, that person presented well. Is it because of my skin color? Is it not because of my skin color, and so on and so forth? How typical foreign trained graduates, how do you handle these scenarios and how do you respond to them? Because
So,
it can actually really make or mar you.
oh yes, oh yes. What I want to encourage everybody to do is I want us to try and, just separate yourself from those kind of politics. Just take a step back as if you're not part of these people and analyze it in 360 degrees. The question is, one, this politics is normal. It happens everywhere. It may or may not be true, but unfortunately, what I've come to learn is that the truth doesn't matter. Facts don't matter. What matters is optics. If people say XYZ, first of all, who is saying this XYZ? Is it the program director? Is it somebody that just doesn't know themselves? If it's program director, it's completely different than if it's someone in PGY2 or someone your colleague. That counts for nothing. But if it's the program that is saying stuff about you, then it's no longer politics. You need to separate yourself from that emotion and ask yourself.
Right.
You need to ask yourself a question. Question is number one. What am I doing wrong? How can I fix it? What's the price to pay to fix what I'm doing wrong? Because I know there's this notion of asking a question, oh, is it because of my skin color? Which there is a factor about that, but you need to first ask yourself, because people have come before you with your skin color and they have blown away the roof, right?
Yeah.
So it is easy for you to say you have skin color, which is true in some cases. However, people have blown the roof with your skin color. So my brother, my sister, let us take a step back and analyze it in 360 degrees. Is this true? To what degree is it true? What is my contribution in these truths? And how can I resolve this? That is the only way because your plan is to protect your integrity and your brand. Your integrity is your brand. You want to protect your integrity with all that you have, with all your hard work, with all your medical knowledge, with every single thing. Your integrity is what wraps it. Without integrity, you have nothing, right? So you call it politics, but it's actually optics. It's the way you are seen. And the way you are seen is by far the most important thing. How much stuff you know that nobody cares about that. What are the optics? So you want to guide your personal brand. You want to guide your integrity. So when you see people talking politics, carry your bag, carry your laptop, leave that place. Do not be involved in side talks. You can just look at them, pretend as if you don't understand what they're saying, carry your bag, carry your laptop, and leave. You have an emergency, or you have to go and see a patient, leave that place. Do not get involved in those side talks. Try to avoid it, no matter how interesting it is. But if the side talk is about you, first of all, if it's coming from your residents, just ignore those people. Except they're like serious, just ignore those people. The residents don't count. Except it's coming from an attending or your program director, like a faculty. Then you have to analyze what is being said and work with the information you have on trying to change
To improve
the
it.
narrative.
There was something.
Now, I would tell you that I personally have experienced wrong or missteps in, people have said stuff about me, and attending have said stuff about me that was flatly incorrect, and I personally did not take it. I said, okay, this hospital said, and let me say exactly what he said. I think he said that I was haphazard in my presentation. Yeah, that's what I was told. He said I was haphazard in my presentation and I need to improve in my medical knowledge. These were his words that he said. And then the question you have to ask yourself is, first of all, who are you? I had 100 percentile in my IT. This guy that is saying that I was having deficit in my knowledge, he finished my own program. And dude, I'm definitely, but that's not the point. The point is you have to ask yourself a question. Who are you? And so when your program, if people want to ask you a question, and that's to the point of Janet, they say you have to, when you do well on your scores, it actually helps you a lot. Now, do not use those scores as a
benchmark now.
yardstick.
Yeah.
It completely means nothing.
Yeah.
However, you need those scores as armor.
You
need those scores. Nobody can tell you stuff. You just need those scores as armor. But after the armor, they don't do anything for you.
Right.
What does everything for you is the way patient talk about you, the care you give to patient in the bedside. Yeah, what the nurses say about you. Because when you treat the patients well, the patients talk about you to the nurses talk about you to the charge talk about you to attending. It all starts from the bedside. Your integrity starts at the bedside. All these scores don't matter. You can get the score, but understand that where your integrity is going to come from is from that bedside. If you do wonders in that bedside, oh my goodness, So
endurance, Dr. Janet, sorry to cut you short. I know there's a lot to say. We've really way exceeded the time, so I'm just going into wrap up kind of segment. We're going to take a lot of questions on so many areas that we did not address. There's an outline on how we should address these things, but we can't finish the entire life and orientation in one day. And I know that these two gentlemen, I think they call men and female gentlemen, have really, given us pure, undiluted knowledge. And we're so grateful. We're going to open the floor to questions, and then comments. I know there's some other senior residents here, people who may have had one or two experience. Direct your questions to Dr. Janet or Dr. Endurance, or make your comments in line with what we've discussed. And if there's one or two other areas that you want to chime in, please chime in. Each person's question, if you are making a question, get your questions direct. If you're going to make a contribution, please keep it within at least 2 minutes so that we can wrap up for the day. And then we're going to take up closing comments, a few other closing questions at the end, and we go from there. This is recorded, and we're going to also share it for generations unborn to benefit from. We're grateful to both of you. Dr. Lillian, I can see your hands up. A brief introduction of who you are, and then keep your comments or questions within 2 minutes.
Thank you so much, Dr. Eddie. Dr. Janet and Dr. Endurance, thank you so much. I am a PGY1 internal medicine here in Georgia, and I am so happy that you guys spoke a lot of things that I was wanting to learn from. A lot of people who think I'm here to just contribute. I'm actually here more to learn. And when my hands were already up, before Dr. Endurance mentioned something about his attending, telling him that his presentation is haphazard, and he needs to improve his medical knowledge. Those are the exact things that I've heard. Right. And Mike, that brings me to my question, Dr. Janet. I think I will be throwing this question to you first, and then Dr. Endurance can, chime in. How did you get to, because I think you just really, I resonate so well with your experience as an intern. I'm like in that situation where you just self-critical. Like many a times I'll tell myself, I don't even know anything. I don't even think, what do I know? Like, I say this because in my program, people keep telling me they're calling them for some kind of, I don't know what they call it, like they are like warning or whatever they call it when they say, okay.
Probation.
What do you say?
Is it probation?
Yes. They're like, oh, they told me I'll go on probation. They told me this one. I'm like, why am I different? Like, I keep asking, like, one guy asked me one day that I think they've called everybody. I'm like, they never called me.
Before
so
I
started wondering, like, why are they not calling me? Because I always tell myself, I don't even know anything. I don't even think I know anything. So my question is, I think one of the places or the areas I struggle with is just, sometimes I think I'm okay, but many times I think like I'm not fluent in presenting my patients. And some attendings just want only a little. Tell me why they're here. Tell me what it is now, and tell me what your plan is. Some attendings want details. Even when this patient is the third day, they're like, oh, I'm just taking over. You have to go, start from the scratch. So then I'm like, oh my God, especially when I'm just getting to take over, like this patient is new and I may not have done thorough thorough, search, get into the EMR, like you said. I also struggle with that. I'm still struggling with that, although I'm better. So my question is, how do you just make your work so easy to give a very good detailed presentation? Did you use any guideline? Do you practice before, you started intern year?
Dr. Jana, before you answer that, hold your thoughts. Yeah, because we all experience this. Let me just say a little, just 1 second stuff. For us in our program, we also experienced it a lot. And one of the things that we now eventually did, we figured out a way. We individualize each attending to figure out how does this attending want it to be presented, because it differs. How does Dr. A, Dr. B, Dr. C, and then we also, in collaboration with the seniors, went to them on their downtime and said, we understand that you have some concerns about our presentation. How do you want a typical presentation to be in this scenario? A, new patient. Scenario B, old patient. Scenario C, patient that they called us on the phone in the ED. Scenario D, patient that was readmitted. Scenario, created different scenarios. And each of these attending walked us through. We took our time to write it, and then we rehearsed it with him. So you mean if he's a patient that was just admitted yesterday that you've never seen, we should say, oh, this patient was admitted yesterday, or this patient is a new patient. And then that introduction, this patient is a new patient. And then we ran through the whole gamut. There's a short presentation, there's a long presentation. Or this patient we've already presented yesterday, he's a patient that we are managing for, CAD that had stent yesterday. And then we now brief. So that was the style that we used. And everybody, so now when we are presenting, we're not starting with patient is a 51-year-old woman. We start with this patient you saw yesterday. So we kind of recall his memory so that he doesn't expect us to run through. Patient is a 21-year-old female, a past medical history of all. So we just say, oh, patient we presented yesterday, he's the one that we're managing for, 21-year-old female, blah, blah, blah. Then we'll do the summary. So that way he doesn't come out malignant. Anyway, Dr. Janet, that question was for you.
Thank you.
That was very spot on. You literally took it out of my mouth. I think this is where expectation comes in. Typically, the program at the beginning of every rotation, attendings and seniors are supposed to address expectations with you guys. And when they say expectation, not just, time they want you to come in, even with presentation as well. What's your name? I forgot. But the person who asked that question, yeah, what you were describing about, oh, they did not call me. How come? My dear, the English for all that thing you're talking about is imposter syndrome. Oh, they will soon catch me. Oh, they will soon find out that I don't know enough. I don't think I know enough. Oh, how come they did not catch me? They didn't call me for warning. Me that I don't really know that. All those things we are talking about. They are all imposter syndrome. That's imposter syndrome. That is imposter syndrome, right? And you have to understand that. Remember, it is not a sprint; it's marathon. I struggled with EMR. Oh, God is great. I struggled with EMR. I struggled with EMR to the point that senior residents were gossiping that, this one is like, she will be on probation. 1 year after, I was the ACP resident of the year. Guys, don't play with God and do not play with practice. Practice makes perfect.
Keep growing.
Don't play with God. Don't play with practice. I say that because the few times I cried during intern year were two things. Frustration from chat review before I add structure to it. That's why myself and Endurance are telling you, talk to your seniors. Have a framework that works for people. You can always add, take out, and fine tune it the way it works best for you. The second reason why I cried on rounds was because even to me, it sounded like what I was presenting is not making sense. I don't know if it's an IMG stuff, because all these IMGs, before this, even sometimes saying the thing where they talk is not 100%, but just that confidence that they exude, it just makes you go into your shell because you're like, me, I can't talk like this. So, so you go into your shell before you know it, you are mixing words. You see the way we've been saying you should have structure with chart review, have structure with presentation. Exactly what Dr. Eddy said. Different presentation style and structure depending on the attending. I have an attending that does not want to hear how old that patient is as your first thing. I have an attending that will tell you, please do not bore me with past medical history. You know how they say, give a good one-liner. Oh, patient is a 21-year-old with past medical history of this. It will tell you, I don't like that because then I anchor. When you give me the chief complaint, then I tend to anchor. So when you start a rotation, ask your senior, what you are expecting presentation wise. You're attending as well, because they will always do soft landing as if people, if you are, is a new team. You can always ask them. Normally, again, our attendees, they do it with us, but just ask them, how do you like presentation? If it's a new patient, how do you want me to present versus if this is a patient we're seeing that, that we've seen before. But at the end of the day, just like we said, basics will always be basics. Use your SOAP. Subjective, objective, assessment, and plan.
Absolutely.
I know. I see you that you asked that question. I know that struggle. I struggled with it. Today, I will use SOAP format. Tomorrow, I will scatter the whole thing. Even me, I'm like, where did I start? Where did I finish? That's why I said practice. Practice because sometimes inside bathroom, I will practice. Sometimes I will call my friends that are senior residents in other programs. I will practice. And just talk to God. Whatever you believe in. Residency is not easy. I won't lie to you. It's not easy. And because you just said that you are an intern, so I'm believing you're transitioning into second year.
In the next 30 days.
In the next 30 days.
Yeah.
So in a way, between me and you, I mean, I don't know how your program is set up, but between me and you, I know that 50% of that burden and anxiety that comes with presenting is kind of gone, because now it's your interns that will present. But you want to be a good senior. And one of the ways you can let them know is, sweetie, I struggled myself. Oh, you don't have to beat yourself up. I struggled myself, but this is what I learned. But for those of you that will be starting in 10 years, have a structure. It will not be streamlined at first, but have a structure. Be thirsty for structure. That structure will help you. Don't start in 10 years thinking you can figure it out by yourself. It's not possible. You will be frustrated. So if you are the type that is timid, try as much as possible to be not necessarily loud, but be out. I don't know how to say it. I don't know how to say it, because I need to also respect audible. Yes. Audible, because these are part of your evaluation. So I'm not going to lie to you people. It's part of, and I know it's unfair. It seems like it's unfair, like, oh, but it's part of your evaluation. So I would say have a structure to it, whether it's chart review, whether it is presentation. SOAP for your presentation for sure, and add on to it whatever you think you need to add. For chart review, again, I also have a structure that I always share with my interns, and they, piece things together, adjust, do whatever they want to do.
Thank you so much.
But that stuff you were talking about is imposter syndrome. And I promise you, pray about it. Understand that the goal is not to be perfect. If the goal is to be perfect, that's where the issue comes from. And you are doing fine. You are doing just, I mean, they've not called you for warning. You are not on probation, and just tells you you are doing just fine.
Thank you so much, Dr. Janet, for that brilliant. We'll be moving on. Dr. Sarome, you have a question. We're taking 2 more last questions, and then I will call it a day.
I'd like to just start by saying thank you so much, Dr. Ed, for organizing this. This is helpful to myself and hundreds of others that would watch this now and later. One is a request for yourself. We're out of time, obviously, but this is a power couple dealing with Dr. Hiram and Dr. Janet. So I don't know, based on popular demand, if you can have like a remake, or if you can have second version with the both of them again, because there's just so much for them to share, and I don't think this one meeting would do justice to all of the multiple knowledge that they have. So if you can have them again, I know they're busy, but for the multitude of us, myself would also benefit. And then that's my
Let me respond to that. Can we have you guys again, Janet and Endurance? We'll talk about that
Please.
behind the scene because I want to respect your time. Yeah, ask your question.
Personally, for me, I told you before, right?
Right.
Again, for those of you that weren't here when I started, this is really what I started my conversation about living a life of purpose and whatnot. This is it for me.
Right.
Advocating for people, helping people, teaching people. So I feel like at any time, I know I'm going to start the old chief residency, but if Dr. Eddie lets me know in time, I am more than willing to come back.
We are moving from the month of June. We're doing every Sunday because from the month of June, we have like three months to September, June, July, August, September, 3 to 4 months to September. So we want to maximize our time. We usually do every 2 Sundays. So there's going to be a lot of talk for those who are coming to residency, those are in residency, and all those. Yeah, direct to your question, Dr. Sorome.
So Dr. Janet, you had mentioned that there are a couple of like really helpful materials that you would share. I'm not sure if you plan to share them in the WhatsApp group or send them to Dr. Eddie privately, or because I would like to gain access to the wealth of resources that you feel would be beneficial for
What program did you
PGY
match,
ones.
Dr. Sarome?
I'm in Canada
Oh,
and I match
Canada.
into
Okay.
family
We can
medicine.
also
Yeah.
reach out directly to Dr. Janet in our group because we don't want people to reach out to people in Zoom because other people are joining us. We're very careful about security. So in the group, you could say, "Hi, Dr. Janet, please can you chat me up?" And then she's gonna chat you up, or
I'm not sure if she has the same name, or if she has a different name.
Yeah, but if you just say hi, Dr. Janet, she's
Okay.
gonna know
Oh,
she's
yeah.
Okay.
the one that
Okay.
the one that spoke, and then she's gonna reach out to you. You can also reach
Okay.
out to her through me, also.
Okay. Sounds good. Sounds good.
And we go from
And
there.
then my final question, Dr. Endurance, like you behind the scenes, you probably don't even know, but a couple months back, I remember in the fall of last year, you shared really helpful tips about, how to prepare for interviews. And I took a lot of the tips that you had shared, and they were really helpful to me in my interview and selection process. And also, thank you very much for the multitude you do. At the start of this forum, you mentioned that there were about 6 things I believe that you said is like a must go, a must wants to have. One of them you mentioned was having a good rapport with an office. And you look like you had like the list of everything. So would like if you could just give a quick recap of the other things that was in your list that we all would benefit from just going into. Or if they've been shared, then
Okay. Well,
Are you going to
congratulations on
share
your
that
match.
in your closing, or I will take more questions while you prepare for that?
Yeah, we'll take more questions. I'll just
Okay,
go through
he's going to
them.
share that in your closing. More questions coming. I'll just read some few comments that we have in the chat. Please, how can I be best? So someone, Dr. Ken asked, Dr. Ken, I don't know if you're here, how best can one demonstrate coachability? There is another question. Thank you for the advice, Dr. Janet and Dr. Endurance. Please, how can we navigate when you are sidelined, alienated? I believe we've talked about that. Or don't share resources with, or your teammates don't share resources with you, particularly because you're the only Black person in the team. I'm sure we've addressed that significantly. Also, if you are not a chatty person, how do you develop this skill talking to everyone? Yeah, I have a shortcut to that. Just come to this group. If you're not a chatty person, you want to develop skill, unmute your mic right now. This is in-house. Start talking, and you're going to grow confidence. If you can't talk in this Zoom of 50 people where we all look alike and talk alike, I wonder how you're going to talk.
As a side note, I'm sorry for interrupting you. I'm not a chatty person. I'm not a outgoing person. No. I'm not a chatty person. Should not be in your vocabulary. If you are a physician in the US, take that I'm not a chatty person outside. If you are not a chatty person, you know what that means? You are not a successful doctor. You are going to come to US and you are going to fail. Or at best, you are going to struggle. So you understand that what is going to keep me from achieving my goal is, in quotes, I'm not a chatty person. You need to take that I'm not a chatty person out. You need to cast and bind it. We need to do like 14 days fasting for that stuff. Okay? So I'm not a chatty person. You should absolutely find any resource you can to do away with that I'm not a chatty person within the next few days, or just keep working on it. But you have to become a chatty person because everybody talks a lot in this place. They talk for no reason. They just talk a lot. So it's part of what you need to work on too.
Absolutely. So other questions, I'm just throwing them so any of you can, jump on it. When you don't know the answer, when you ask about a clinical question, how do you say you don't know? And then Lillian put a comment there. How do you manage reading, keeping up with studying? We've already talked about that. Do not even know your face. Okay. All right. So some of these questions in the chats, and then other ones, feel free to unmute your mic. We'll take 3 more questions. We're not going to cover everything today. We're going to do our best to bring this panel back. There's going to be a last final session next week. 2 other people are going to come to talk. And we also try and see if I can bring in Dr. Janet and Dr. Endurance again so that it can be like a fuller house, or everybody like a fuller panel. I usually want to do 2 people so that they can have enough time to express themselves, but we'll see how it goes. Any final thoughts, final comments, answers to questions, Dr. Janet?
My people, final thoughts now. We've again take whatever you can pick from the things we've said, take it. For me, I would say nothing can prepare you for the curve. I don't know how to do it's just one of those things you have to experience. It's just one of those things. But again, do not forget the 3 Gs. That's what I swear by. It's worked for me. God, your goals, and growth. Those 3 things, if you key, personally, I've not seen anything that is God-centered that doesn't work. I know we have Muslims here, we have Christians here, right? Technically, we serve the same God, but be God-centered. This is not the time to be careless with God. Let grace speak for you, right? Grace will speak for you, but you also have to be very God-centered. Be very, very passionate about your goals. Don't get distracted by the noises. Exactly what Dr. Endurance said. Some people will not just like you, and it's okay.
Yeah, you're not there to be liked,
You're
actually.
not there to be like, you're not actually
Yeah,
there to make
you're there to
friends.
just get your job done, be
Get
professional
your
and
job
go.
done.
Yeah,
Exactly. So please, very important. Oh, that person, I don't think that resident like me. Oh, I don't think that should not be your concern. You are there to learn.
yeah. If
You are
you're
there to
lucky
do
that they like you, fine, but you're not really there to be liked.
exactly the same way you don't go there for friends. Now, if beautiful friendship comes out of the residency, well, glory be to God. If it doesn't, to start with, that was not the primary reason why you're there. Like myself and endurance have said a lot of times, the nurses are your friends. Those are the ones you want to be close to. I remember
Nurses have
starting
to
as
like
a
you.
huh?
Those nurses have to like
They
you.
have to. They have to. Honestly, those people, you should be more scared of them than their attendants. Especially for us in our MICU, our ICU, this thing. I remember starting as a senior. I went to meet each and every one of them. I said, I'm new as a senior here, with a smile on my face. So I said, please help me, help me. And they were like, no, we got you. You know why? Because when you come in the morning, oh, by the way, guys, if you have any rotation where it's closed units, like our ICU, where you have
They tell you what happens.
go and talk to your nurses. Oh, don't go and be
Mm.
walking up and down like the patient, shock. Go and talk to the nurses. Oh, how was your night? Oh, they just brought this patient. Oh, I'm so sorry you had a long night.
Stressful night,
So
yeah.
what happened? Collect update from them. You know why? They saw those patients 1 million times than the attending. The attending probably saw those patients maybe twice throughout the night. They went in there more times. So, guys, God, growth, and remember, it is not a sprint, it's a marathon. It never
It's
ends. Learning never ends. So, guys, don't worry. Do like this. You'll be fine. I promise you'll be fine. With all these things that we said, some people will still cry the first 3 months, and that's okay. I know I did, and I always want like incoming interns to know. Oh no, it was not an easy one for me. Well, see, we made it. So I wish you all the best. I wish you all the best. And
Thank you
remember, you've
so
not come
much.
this far. God has not brought you this far just to be here.
Let you
So
down. Right.
yeah, it would not.
The 3 Gs again is God, growth, and the
And
top
growth.
Goals, God, goals, and growth.
God, goals, and growth. Thank you so much. Dr. Endurance, final thoughts, and then there were some 6 things you said you wanted to go over. Final thoughts in 2 minutes.
Yeah, so I mean, this is by far just being here and understanding that, what we're doing here is just trying to ease your way into residency. It's difficult to prepare holistically, like Janet had said. I just want to piggyback on what Lillian.
I think Endurance has frozen. Endurance, we stopped hearing you at, I just want to piggyback. I think you've frozen. We stopped hearing you at, I just want to
attending, you
piggyback.
have to ask yourself, am
I
I
think
still frozen?
You froze at, I just want to piggyback on what, and then
But can you hear me now?
Yes, we can hear you now.
Okay, so I also say about Lillian when she said sometimes attendees don't like you, sometimes there's no amount of presentation you present that is good enough for them. That's fine. You only have to make sure that you are checking yourself and making sure you're doing what is needed. You are not entirely, you are putting yourself to a standard and you're living up to that standard. And it may not be good enough for everybody. That's fine. Just move on. So the 6 things I want to say is, in summary, we're all here talking about how to be a wonderful resident. The first thing is you have to divide your residence into phases. The first 3 months, you are trying to settle in. You're not trying to impress anybody. You're not trying to, you're trying to settle in. And what you're supposed to do is the first thing, go there, understand the unspoken rules. So number one, in the first 2 months, 3 months, you're understanding the things that are not said. You are just observing how they interact. You are observing how they round. They expect the documentation. You just ask questions. You're just asking questions. You're trying to build trust. That's what you're trying to do in the first 2 months. Okay? You're understanding the culture, the hierarchy. That's what you're trying to do. You're not trying to dazzle them. No. First 2 months, understand how they flow. That's number one. Learn the unspoken rules. Number two, you're trying to master the workflow efficiency. That's one. How do I get it done? That's two. And how do I get it done in time? That's what you're trying to do in the first 3 months, So managing your time, how to write notes, how to chat review as fast as possible. That's what you're trying to do in the first 3 months. Now, it's going to take you more than 3 months. It's going to take you more than 3 months. Can you guys hear me?
Yes, absolutely. Yeah. Good to hear you.
It's going to take you more than 3 months, but if you focus on efficiency early, you will be able to ask the right questions. You'll be able to ask the right questions, and that will help you, acclimatize to residency soon enough. So that's number two, mastering your workflow efficiency. Number three, you are also trying to focus on your clinical skills deliberately. So taking history, examining your patients, communicating with your patients. So taking history taking, go back and brush history taking. Now, we all know that there's a shortcut to go to appendicitis. If I see a patient, they are rolling up and down, they are holding their right, I just go touch the stomach, bam, I know that is acute appendicitis. No. You have to go back. Most of us, we forgot to go back and start how you want to take your history from start to beginning. Sorry. From start to beginning. From start to beginning. You want to take that history, babe. You want to take your history from start to beginning. You just learn the process again. So that, because your senior residents are looking at you when you're taking this history, right? The patients, they know, because most of them have been to the hospital 10 times. So they know when you're off, So everybody's looking at you in those phases. So you want to brush up on your history taking, communication with patient, examination. Then you also want to, guys, forgive me. And then number 4, you want to hone your communication skills. And like I said, communication skills is where the money is. Communication skills is the most important thing you can do, because that is all you do as a doctor. You are talking to the patient, the patient's daughter, the patient's son, talking to the social worker, talking to the nurses, talking to the attendant, talking to your senior. You are always talking. So if you know that your words that you don't pronounce, you speak very fast, you know that people don't hear you as much, you want to now start speaking deliberately. Record yourself. Put your camera, your phone, record yourself and listen to yourself. Like, then try and fine-tune what you are saying. Because I can promise you, you will also not hear yourself sometimes. Some of us are not as self-aware as we should be, which is fine. But now you are with people that cannot necessarily hear you. So you have to be able to find that balance. Communication skills is by far the most. Because you have to, the inflection of your voice when you want to give bad news. And there's a culture here, because when they say, so for example, say, I was, my son just died, And you're like, here they'll be like, oh, I'm so sorry. They are very, very vocal with their feeling.
Yeah.
They're very vocal. In Nigeria, we may use our face. Jesus, there's a way we do. It's different. Like here, we use, but here they speak their emotions. So you have to learn those culture stuff. You have to. So that's number 4. Number 5, you have to seek mentorship and feedback. 7 out of 10 people, 8 people will out of 10 people, 3 people will like you, 5 people are just on the fence, then 2 people don't like you. And that's okay. Find the people that like you, find the people that want your progress, people that want to advocate for you, and seek out honest feedback from them. It might be a senior resident, it might be an attendant, but find people that can tell you what you're doing that is good and what you're doing that you could improve on, and then focus on those things. Look at your skill like this. There's hard outcomes and there's soft endpoints. Hard outcomes are the things that move the needle. Soft endpoints are the things that make the moving the needle look good. Focus on the hard outcomes. Girl. Sorry, guys. And then lastly, contribute and try to lead thoughtfully. And that's with respect to teaching your medical students and trying to show up. So after I matched my program, the next year we had 2 Nigerians, 1 Ghanaian, 1 Sudanese, and 1 Egyptian. They just checked the whole Africans. The whole program full with Africans. What does that tell you? Now, among those people, 2 of them are now chief residents. One of the Nigerian guys, he was so good. Anytime we call Jeopardy, we have to cover resident. The guy shows up. No question asked. He's always consistent. If you ask him, oh, we have 1 resident is sick, we need you to fill up, can you come? He will not ask questions. He will not be like, oh, why do I have to call? You guys called me last week, why are you calling me this week? No. Some residents will be asking many, many questions, but him, he didn't ask those questions. He was very, very, that kind of intern that is always wanting to do more and do more.
Right.
That's how he became chief. So you want to contribute, you want to lead, you want to be consistent, So I think those are the 6 things I'll give. So learn unspoken rules, master workflow efficiency, build clinical skills deliberately, hone your communication skills, seek mentorship and feedback, and contribute and lead. And then we'll see you guys in 3 months and talk about how your first 3 months went, and then we can talk about how you can become fantastic resident, best resident, and do all your stuff.
Thank you
I think
so much.
IT happens in September. We can talk about
September. Yeah.
Yeah, we can talk about. We can start preparing for it now. But yeah.
Thank you so much. I hope everyone is taking note. This is IMG Research Academy, now Global Research Initiative. We've been privileged to be blessed with a lot of chief residents, well over 8 chief residents in our group. 2 of the most outstanding of them, Dr. Janet Omole and Dr. Endurance Bayeka. I tried to pronounce that name properly, have given us that 2 hours of their time, spilling undiluted knowledge on how to succeed in residency. Thank you so much, Dr. Janet. I know you're full of hope. Last message of hope to all those who marched and those who are going to march, and Endurance. Last message of hope to all those who march and those who are going to march.
For those of you that marched, again, congratulations. I'm so proud of you. Again, like I said, you'll be fine.
You'll be all right.
Just don't forget who you are. Don't forget who you are. Don't forget your purpose. Cling on to God. And like something that Endurance said that I do agree with also, you need to seek mentorship. You can't do this stuff on your own. You cannot. Pay it forward. Very important. I echo what he said. Before I came into my program, we had 1 Nigerian as well. After I came into my program, we had like 5, 6 Nigerians too. Pay it forward. They are watching you. So if you do well, it's with that confidence you can sit there in front of APD or PD to say, I have recommendation now, But like he said, if you are the type they call to come and help somebody, you're already grumbling or changing your face is speaking. So you'll be fine. That I will tell you, you'll be fine. You will look back this moment and you'll be like, why was I so nervous? It's normal. It comes with the package.
Thank you so much.
For those of you that is hoping to match, keep following this group. Dr. Eddie is you're doing an amazing job. I love it, love it, love it.
Thank
You will match. You will match. Exactly when you will match, obviously, I'm very hopeful that you will match as soon as possible. But just start to jot things down and just start to prepare yourself. It's gonna be you very soon as this time next year, right? But at the end of the day, everybody will be fine. And you guys, you need anything, you want to ask me anything, I would send my details to Dr. Eddie to put in the group. In case that gush of anxiety, wears you again like glove before the residency really starts, reach out to me. I am more than willing to talk to you and help you through it.
Thank you. That was a brilliant message of hope from Dr. Janet Omole, one of best of the best. Dr. Endurance, any final 1-minute message of hope to those who matched and those who didn't match? Because it's doable. It's doable. No, we can't. You're mute.
To the people who matched, congratulations. This is fantastic news. And the hardest part is done, actually. The rest battle is just in your head.
We stopped at the rest is just in your head.
Easier than you think. Congratulations. The people, can you guys hear?
Yeah, we can hear you
now.
Yeah.
I don't know. I'm sorry. It just keeps cutting. For people who are going to match, who are hoping to match, just look at your application, figure out the weakness in your application, and try to cement those weaknesses in your application. Reach out to mentors. When I applied the first time, I did not match. I know most of you be like, I did not match. I did not match. Not only did I not match, I had 0 interviews, guys. So it's not the person that matched today and the person that matched tomorrow. The difference is actually very slim. I had 0 interviews completely. So yeah, the difference is find a mentor, someone who can point you in the right direction. Mentorship is very important in the US. It might not be very important back home, but it's super important here. Find someone who can look through your CV, look through the weaknesses in your application, and then apply. Of course, you have to have God factor, very important. But also try to do your own homework. Well, I wish you all well.
Thank you so much. On that note, we're grateful. This is IMG Research Academy. My name is Dr. Kobe Edwards. I'm usually the anchor of this program. We've come to the end of part 2 of how to excel in residency. See you for part 3 on how to excel in residency, and then for other programs that we have moving forward in the group. We look forward to having an amazing year again come March next year. Thank you and God bless.